Well, let's get the show on the road. Welcome, everyone. I wanted to welcome everyone once again to our webinar. I am your moderator and your host, Dr. Lauren Levine. As usual, when we do a Golden Dent webinar, we have a great turnout, close to 800 people registered. As I do for all these webinars, my first and foremost, I want to make sure that everyone's staying healthy and safe out there. I commend you all for being here this evening, staying up with your continuing dental education. Most of you know that, even with what's been a pretty topsy-turvy last 18 months or so, the need for education never ends. And of course, you're all showing that by being here this evening. As usual, I'm going to do a couple of minutes of housekeeping. I want to make sure that Dr. Nazarian can speak for as long as he needs. We also want to leave time at the end for questions. Typically, when we do these webinars, even with 800 people, I'd say usually about at least 3/4 of the people have been here in the past, and a quarter or so maybe it's their first time here. So if you're new to the webinars, the format is pretty much the same. You will see a little box on your screen that's called the GoToWebinar Control Panel. You type in your questions as you think about them. We don't do verbal questions. I apologize. When we have 800 people, it's impossible to do that. I never know how many questions we're going to get. Sometimes we get 5 questions. Sometimes we get 55 questions. I'm going to do my best to get to as many as we can. We usually have a pretty hard ending time at 1/2 so we want to make sure that we try to get as many questions in. I'm the only one that can see the questions, so if we don't get to your question, you can blame me, but I will try to consolidate some questions and see what the themes are and do our best to get to as many of these as possible. A couple of things to look for in the next few days. The webinar is recorded, so if for some reason you can't stay until the end or you're not hearing this now because you're not here yet, don't worry. We will send out the recording. That usually goes out within a day or two, so keep an eye on your inbox for that. During the webinar, Dr. Nazarian is going to be demonstrating a few products and systems that he uses, which are exclusive to Golden Dent. I could not do these webinars without their sponsorship. It takes a lot of effort and time to get a great speaker like Ara to come in, to design the invitations, to handle the CE. So we thank them for their ongoing support. Speaking of CE, I get numerous emails after every webinar, so I'm going to mention this at least twice this evening. The basic process with the continuing education is that if you're here and you stay on for the webinar, you're going to get the CE. There's nothing that you physically need to do. There's no quiz, there's no test, there's no registration, nothing. I send them a list of who was on. They look to see how long you were on. Obviously, you're not going to get a CE form if you're only here for 3 minutes. But if you're here for the bulk of the webinar, they will send that out. That can take up to a couple of weeks. They have to go through that whole list. So please be patient. Keep an eye on your inbox. Check your spam folders. But it does go out. If you don't have it within a couple of weeks, just let me know, and I'll be happy to follow up on your behalf. So with that out of the way, once again, I wanted to welcome back Dr. Nazarian. He maintains a private practice in Troy, Michigan. His emphasis is comprehensive and restorative care. He's a diplomat of the ICOI. His articles have been published in many of today's popular dental publications. He's consistently listed as a top dental educator. He's conducted just so many lectures and hands-on workshops on everything from aesthetic materials to dental implants, all throughout the US, Europe, and Asia. He's a faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, and immediate dentures, and he founded the Ascend Dental Academy, which teaches all aspects of dental implants. So, Ara, we're thrilled to have you back and really looking forward to tonight's presentation.
Thank you, Dr. Levine. Good evening and welcome, everyone. This evening, we'll be talking about same-day teeth, from immediate implants to full arch implants. If we take a look at the examples on the screen, you can see in today's society, people don't want to walk out without a tooth. And if we're able to place implants immediately into an extraction socket, whether it's one tooth and the patient doesn't need to leave the office with a flipper, but in fact walks out with a fixed temporary crown restoration, or if we're looking at a full arch where a patient presents with non-restorable teeth and we sedate them, we extract all the teeth and level the bone, and the patient walks out with fixed temporaries. This is what today's society is wanting if they need to have a tooth extracted, whether it's one tooth or multiple teeth. In fact, today's society demands a specific type of dental implant based on these needs. In other words, we need an implant in our profession that, number one, achieves good primary stability, has a slightly tapered design to increase that stability, has aggressive threads in its pattern, has an internal connection that's stable and easy for the laboratories to work with, doesn't require multiple steps to place, can be immediately provisionalized, as we've mentioned already, can be used in any type of bone. We don't want a certain type of implant for D1 and D2 bone and a separate implant for type 3 and type 4 bone. We want an implant that can be used in any type of bone because we don't want a huge armamentarium, one that's got the stable connection and platform that can be used for multiple types of restorations, whether they're screw retained, cement retained, or even overdentures. And most importantly, we need an implant in our profession that's cost effective for the dentist and the patient. To pay over $200 or $300 for an implant in today's day and age is a little overkill. This way, it makes dental implant therapy affordable for our patients when we have an implant that's cost effective. Here's a great example of a patient who presented to our practice. We did the workup and did a Cbct. We had a prosthetically driven implant treatment plan. And so in one appointment, we sedated the patient, we removed upper and lower teeth, leveled the bone, placed several implants in both arches, and the patient walked away with fixed immediate temporaries. Many times patients present to my practice for a consultation, and the biggest question is, how long will it take to go from A to Z in my treatment? In other words, how long will it take to be done and to walk out with finals? We could potentially put the finals in the same day, but what I found is after the swelling goes down and after the ridge is healed, patients tend to have a larger gap between their hybrid restoration and the ridge. And so a lot of practices will go ahead and make a modified ridge lap. Our goal with these restorations is to have more of a convex underside that is easily cleaned. So my goal is to provide a fixed restoration, allow the area to heal, and then 4 months later, take new impressions and provide the final restorations. So you'll see that in my teachings this evening, and also this is what we also go over at the Amplify Dental. So here's a great example again, restoring somebody's whole dentition, doing a full mouth reconstruction with Cbct guided implant therapy. So let's take a look at the first example. It doesn't always have to be guided. So let me show you some examples that are non-guided, and then we'll continue with some guided cases. This patient presented to my practice for a consultation. In the upper arch, she had a complete denture. In the lower arch, she had a partial that she hadn't worn in about 4 or 5 years. About a year ago, she had recently lost the incisor in the front, and she wanted to talk to me about possibly getting a new partial or adding a partial to her existing lower partial. So the first thing I said is we need to get a 2D and 3D x-ray to, number one, identify if these teeth are healthy enough for a partial. Now, we already clinically can see as dentists that these are not healthy teeth and that in fact we will have to remove them. However, I don't want to jump to that diagnosis until I have a radiograph that I can illustrate to the patient that yes, indeed, these teeth are not very healthy. In fact, they're severely decayed and some of them are actually somewhat infected. We review the options with our patients when presenting treatment plans, especially treatment plans that are going into higher numbers for our patients as far as cost goes. So the first treatment plan is obviously a new set of complete upper and lower dentures. We could do upper dentures opposing a lower overdenture, whether they're small diameter or traditionally diameter type implants. And then obviously we can offer overdentures or fixed over fixed. Uh, because of the patient's budget, we chose to go with an overdenture on the lower arch. So our goal was to make a new upper denture and overdenture on the bottom. We also inform the patient of the different stages of bone loss and that the implants do help slow down that process. The more implants we place, then obviously we can stop the resorption of the bone even more because we're using these implants to stimulate the bone. This is a great example of a model that we use. Ideally, in the upper arch, we would love to go with an overdenture or fixed, but because of patients' budgets, we'll just stick to overdentures in the lower arch. And so this is what we presented to the patient, and we were able to maintain that limit in her budget. So if we take a look, we want to anesthetize the patient. We've already fabricated a new upper denture and a new lower overdenture or immediate denture that we will pick up in the mouth immediately. Utilizing the physics forceps, we're going to atraumatically extract the teeth. If you notice, there are 4 physics forceps. They're divided into the categories and the sections of the mouth. So we have the upper right and the upper left. We have the upper anterior, and then we have the lower universal. Obviously, in this case, we would only be using the lower universal to atraumatically remove the remaining dentition in her lower arch. If you take a look, you can actually see how severely decayed some of these teeth were in fact. Now, a lot of dentists would like to just jump and place implants into the ridge. And I can tell you, as someone who places implants all the time, you want a foundation that is somewhat flat. Trying to place implants freehand into these sockets is not a very easy task. And you're not always going to be in the most ideal positions of bone. So if you are going to be placing these implants freehand, I personally recommend reflecting a flap, leveling the bone, and now using that leveled ridge as a guide, we can place the implants with the sufficient amount of bone on both buccal and lingual aspects of the ridge. So here you can see I've already extracted the teeth. I've reflected a minimal flap. Obviously, we don't have to reduce any farther distally because number one, those areas are resorbed. Number two, we're only placing the implants in about the 22 and 27 positions, or as we call it, the canine positions. So you can see we've reflected a flap utilizing this instrument. I helped design this for Golden Dent. This is called the reflector, and it works very well in being able to reflect a flap for a full arch or even a section or quadrant. In addition to reflecting the flap, our goal is to level the bone. Golden Dent has this great burr kit that has a leveling burr that goes into your straight nose cone. The one that's to the right of that pear-shaped burr is the round burr, also used for leveling full ridges. Then we have a diamond burr that goes into your high speed to further smooth the interdental areas of bone. We have a sectioning burr, which is in the middle. And then lastly, on the left, you see these 2 diamond, very coarse diamond burrs that go into your surgical handpiece. And these are used to remove any type of cyst or granulation tissue from the socket. So here you see we have a nice leveled foundation or ridge. We can ideally start drilling for 2 implants for snap-in denture or overdenture as we know it. Using the add-in system, this is their premium kit for their Touareg internal hex implants. You can notice they have some long drills and short drills. They also have the tri-step drills. So first, we're just going to start with a pilot drill and identify if we have the appropriate angle by placing paralleling pins. And again, this is all done freehand. And you can see that we're quite parallel in our first pilot drill. We take a radiograph if necessary to make sure or ensure that our angle is appropriate. Obviously, we can clinically see this. So our goal is to go ahead and place 2 implants. Now, what type of bone are we going to be continuing our drilling sequence? In the anterior portion of the mandible, usually we're finding that to be more of a D1, D2 type of bone. So when drilling, you don't want to underdrill, but in fact, you want to step up to the final drill in any system. If you underdrill, then you may not get the implant all the way down without putting too much torque, and then you can cause osteonecrosis. So using the appropriate progression of the drills, we drilled sufficiently to place 2 Touareg S 3.75 by 13 length add-in implants. And so this is what the packaging looks like. And a close-up look at the Touareg S add-in implant, you can see the aggressive threads. You can also notice that the V threads at the tip of the implant eventually turn into square threads. So if you recall, the first thing we talked about this evening was an implant system where we can place it in any type of bone, get appropriate fixation until the implants osseointegrate. When you're getting 60 to 70 Newton centimeters with this implant in a D1, D2 type bone, then I feel comfortable placing the locator on that and loading the overdenture. Obviously, we won't put the most retentive locators in there, but I feel very comfortable using this implant now for a while, and because of its design, and especially the type of bone that we're placing it in, to immediately load these implants for a snap-in denture. Some of the advantages of this implant are the double lead threads. As we talked about, the high primary stability, even in type 4 type of bone, the bone condensing property and the self-drilling and self-cutting of this implant. In fact, we can redirect it when we're in soft bone to a direction that we like. The beauty of these implants are whether it's a 3.5 diameter or 6 diameter implant, they all have a 3.5 prosthetic platform. So let's just say you place a 375 and for some reason you have to put a 5mm implant, you can actually still use the same prosthetics that you were planning on with the smaller implant because they all have the same 3.5 prosthetic platform. Here are the different lengths that are offered in not only the Touareg S, but also the Touareg OS, which is the OsseoFix that will show some cases later this evening. So here we've placed the implants into the sockets. We see that the placement is most ideal. And so we're gonna take a baseline reading with our penguin. This illustrates the resonance frequency analysis. These are available through Golden Dent. It gives you a great baseline reading, illustrating the stability of this implant. If we were to take the reading 4 months later, our goal would be to see that it's a higher number. And in fact, with a number of 74, that's actually quite high. So these are available through Golden Dent. It helps reduce treatment time because you can check and see when these have integrated, and it helps to manage risk patients. In fact, I have several dentists that refer to me for implants, and before I send the patient for the prosthetics to the general dentist that referred to me, I will actually take an Ostel or Penguin reading and illustrate that these implants are indeed integrated before I refer them to the dentist. We saw that it had a great torque and a great reading, so I feel comfortable placing a locator abutment on there. Usually when I'm doing immediate placement like this, I'll go to about a 4 or 5mm height locator so that when I suture the gum, the locator is still sticking out of the gum and that we can place the prosthetic cap onto. Now, before we suture this patient, I do in fact want to fill the voids with bone grafting material. So here's an example of the bone grafting that we used. This is the Goldos DBM from Golden Dent, you can extrude it through the small tip that you see at the apical area of the syringe. If you were to remove the whole white cap off, then you can place it into larger sockets. In this particular case, obviously, we're going to keep that on so that we can place it in the most ideal positions and fill the areas that illustrated the void with bone grafting material. So in this slide, you can see no threads are apparent in the voids of where the canines were, as well as any other sockets we're going to fill. Here you can see we've used chromic gut to suture the area. And then we don't want to pull the sutures when we do the hard pickup of the immediate denture. So one way to do it is to trim rubber dam material. And then I will show you another way in another example utilizing seafold towels. So this is one way. We're going to trim this down a little bit and then do the hard pickup. The material that I like to use for hard pickup is Tokiyama Rebase 2. They've just recently come out with the Rebase 3. It's a powder liquid mixture. Here you can see we're mixing it, and then we place it in a monojet syringe, extrude it into the areas, and you see we've picked up the two housings for the zest locators. We're going to go ahead and trim any excess acrylic, and then we'll put the 1.5 pounds of retention on either side. So this gives us a total of 3 pounds of retention for this patient's overdenture. Here you see the immediate denture that's been converted to an overdenture. And notice we don't have to have huge flanges on these dentures. We can trim them actually just a little further if necessary to make the patient feel comfortable. Looking at the immediate radiograph, we can see the position of the implants and in fact the areas that we have grafted as well. Later, if this patient would choose to upgrade to a fixed restoration, we could place 2 anterior to these implants and maybe 1 on either side distally to provide a hybrid type of restoration. So in this example, we illustrate a pretty easy approach to an overdenture. Before I was placing implants, I hated doing removable dentistry. Now that I've had implants in my practice for over 20 years, doing a lower overdenture with the basic of just 2 implants with some type of overdenture attachment makes it much more enjoyable. Here we're comparing the before and after radiographs, illustrating our locators and how they're all connected. So let's take a look at another example of overdentures. This patient presented with quite a bit of advanced periodontal disease. A closer look illustrates how bad he's got bone loss, but in fact also some of the hypereruption of his teeth because of the malocclusion. This is the retracted view. So obviously looking at the occlusal aspect of both the maxillary and mandibular arches, we can clearly see that these teeth are no longer restorable. We're going to look at the radiograph and we can confirm that yes, this patient does have advanced periodontal disease. We want to remove these teeth, remove the infection, clean the sockets, and at least place a minimum of 2 or 4 implants. This patient said that he eventually wants to upgrade to possibly fixed in the lower arch. So we actually ended up placing 6 implants for this patient. Using my Carestream 8100, we went ahead and planned for the virtual placement of 6 implants. This way, if the patient wanted to upgrade to a hybrid, all we had to do is remove the locator abutments, screw in multi-unit abutments, and create a fixed restoration. Instructing the laboratory, we don't just say, please create immediate dentures. We want to draw on several photos that we supply to the dental laboratory of where we want the centrals, where we want the smile line, what type of occlusion do we want. Some of these teeth have hypererupted, so they've created sort of a roller coaster bite. So yes, it's a simple drawing that we do, but we're informing the laboratory what we're looking for in the setup of these teeth. Obviously, we cannot try in a wax try-in because he's got too many teeth to utilize or to have to extract before we do it. Now, one thing I've noticed is patients want to have the surgery done in one visit. In the past, we would take the posterior teeth out, leave the anteriors, and then do it in various stages. But in today's society, people want things done faster, more predictably, and efficiently. So for that reason, my goal is to try to do all the surgery in one visit. Here we have the immediate dentures that the laboratory has fabricated and ready for the day of surgery. As you can see, we've anesthetized the patient, noticing the blanching of the tissue. We're going to utilize the physics forceps to extract these teeth. Again, even though these are periodontally involved, sometimes you can get a root tip that breaks. So we still want to use some type of leveraging action, as is in this example, utilizing the physics forceps. So we'll loosen the teeth up utilizing the physics forceps, and then using the golden force forceps, we'll go ahead and further extract the teeth one at a time. Again, our goal is to preserve the buccal plate as much as possible. So the black forceps that you see are the golden force, also from Golden Dent. There's standard series of upper and lower, and then we have some root tip forceps, an ash forceps, and an anterior forceps. Now, in some of the stubborn areas of root tips, before we can engage those with any type of forceps, I like to use this as a pre-step. This is the wedge. It almost works as a mix between a luxator and a periotome. And so we'll further rotate those to get those out atraumatically. Again, this is the burr kit from Golden Dent. Once we've extracted the teeth, we'll use these coarse diamonds in our surgical handpiece that extrudes saline, sterile saline into the socket, but it helps to further remove any granulation tissue or cyst from the socket. Notice they are a longer shank to be able to get into the socket. Now, in this particular case, because the guy had periodontal disease, there was no need for leveling in the upper arch because the ridge was essentially pretty flat because of the periodontal disease. So instead of reflecting a flap and creating more trauma for the patient, we just went ahead and placed some BioViva, which is a hemostatic gauze type of dressing that's made of cellulose, and this will disintegrate. And in some cases, it can eventually turn into bone if you have wider than 2 millimeters of a buccal plate, but it helps to prevent dry sockets, and it also controls any bleeding. You do still have to suture around this so that you don't lose the hemostatic wound dressing. So this is what it looks like once it's wet. As you can see on the patient's right side, we've packed it in, and you can see the left is just starting to get wet with the patient's blood. And then we'll go ahead and further stabilize it by suturing with chromic gut. Primary closure is not necessary with this material. Here you see the immediate denture that's placed in. And in fact, in this case, it was such a nice fit because we didn't have to do any leveling of the bone that I believe in the upper arch, we didn't even have to use a soft reline. Same visit, we'll go ahead and continue to the lower arch. So we're going to atraumatically extract these teeth. We're going to start with the pre-step of the wedge. And then in some cases, we'll use the physics forceps, or in others, we went straight to the golden force forceps. And you can see we extracted all the anterior teeth. Here we have the Adin-Tourig OS implants. The OS stands for the OsseoFix. I'm finding that I'm just using the OS now for all my immediate load cases. I use the OsseoFix because it accelerates the healing process so we can go to the final restoration much faster, because it does increase optimal osseointegration because it's a wettability, and obviously it increases long-term success. So if you take a look at the lower right image, you can see almost like these crystals on the surface of the Tourig OS, or as we call it, OsseoFix surface. The design of the implant is exactly the same as the one, the Tourig S, which you saw in the previous case. So it has all the same advantages in the shape, design, and taper, as well as one prosthetic platform. I maintain the posterior teeth just to stay on target of the ridge. I checked the stability of these implants, so they had a very high implant stability quotient. And for that reason, I went ahead and placed locators. Now, in the areas of the voids, I will place grafting material. We'll suture these areas. And now we'll go ahead and extract the two posterior teeth. Here you can see we've extracted those. In those sockets, we went and placed osteogen grafting material. And in the anterior area, we placed allograft, which was the golden os particulate. We try in the lower immediate denture, and now we have to relieve the inner portion of that denture. So we first want to capture the bite. Once we've captured the bite, we'll use a silicone or bite registration to identify where we need to further relieve the areas of the locators, because we still need some extra room for the housings. Usually we need an extra 2.5 millimeters for the housings that snap onto the locators. So we'll take a round burr in the laboratory and open these areas up. Once the areas are open, we'll place the adhesive for the Tokiyama hard reline. And instead of using the rubber dam, in this particular case, I actually cut strips of C-fold towel. Now, the beauty of using the C-fold towel is you don't have to go around the encapsulations of the housings, number one. And number two, because of the wettability of the C-fold towel, it actually sticks to the area. So if we were to cut strips of rubber dam, they would not stick to the ridge or to the gum tissue. The C-fold towel, in fact, when it's wet from the patient's blood, will actually stick to the area, thus preventing the hard acrylic material getting stuck into the sutures. So we'll mix our Tokiyama base, load it inside the denture, position the patient back into the bite that we got before. And you can see the hard reline is setting. Once it's set, we'll remove the upper and lower dentures, trim the lower denture. And in this case, we didn't want to load the most posterior implants. We had better fixation with the anterior 4. So for that reason, I went to the 1.5 pounds of retention for the anterior 4. And for the most distally placed implants, I just went with the processing encapsulations. So this is as the patient's coming back to. We're going to check the bite further, trim any excess acrylic. And so this is the immediate post surgical Panorex, and you can see the placement of the implants. If this patient later preferred to go with a fixed hybrid on the lower arch, then we would be able to do it. If he wanted to go with fixed in the upper arch, we would definitely have to do bilateral sinus lifts. There just would not be enough bone to do fixed in the future unless he went with further grafting. So if we compare the before and after, this is the implants immediately placed with the addition of grafting. Here we see the before and after images, not only clinically, but radiographically. 4 to 6 weeks postoperatively, we can see the areas healing. We see that we have to go over the oral hygiene instructions. Notice how the upper ridge, without any leveling, just using the BioViva hemostatic gauze, we were able to place the ridges nice and balanced, as well as the lower. Here we see additional flash of material that we're going to just remove, as you can see in the lower picture. So this is something that most general dentists will be able to do with training. In fact, this weekend we're doing a course with Amplify Dental where we're teaching extraction, leveling, grafting, and immediate dentures or immediate overdentures. Well, not every case is going to need an immediate denture. You're still going to get patients that present to your practice that have a root canal tooth that broke off at the gum line. It probably was previously endodontically treated. In this particular case, as we look at the radiograph, you can see not only was this radiographically treated, and not only was there a post, but there were 2 pins. So it looks like this tooth may have broken on this patient in the past. So we're not going to try to perform urodontics. We know with this patient's bite and some of the forces on her dentition, we in fact will restore this area with an implant. So the first thing we'll do is get a Cbct utilizing our Carestream Dental 8100. And in a Cbct, we get 4 panes or 4 windows of images. We get a cross-sectional view, as you can see, that is enlarged. We get an axial view, a 2D view, which is like a panoramic view. And then our goal is to stay within this ridge of bone. So if we take a look, if we were to just take the tooth out and place an implant into the socket, we would be way off in regards to the bone. Dr. Scott Gantz taught me a long time ago that you want to stay within this triangle of bone. So if you see this triangle that I've identified, that is the ideal placement of where we want to place our implant. We want at least 1 millimeter to 1.5 millimeters of bone around the implant buccolingually. And so ideally, we're going to place an implant in this area. So we identified a width of about 3.75 or 4.2 after we've done our measurements and calculations. Here we can see that this is a 4.2 by 16. This is the Adden Tourig OS implant that we've planned in our imaging software with the Carestream. You can already see that this patient has had several endo, several crowns, several teeth that probably fractured because we see 4 implants already placed in this patient's mouth. Here we have the 4.2 by 16 millimeter length Tourig OS implant. Pittman Dental Laboratory not only fabricated the guide, but they also fabricated the custom abutment. So I like to have these custom abutments pre-made, and I prefer that they're gold anodized. This way, if the patient has a thin biotype, we don't see a gray hue at the gum line. So Pittman Dental Lab does a great job with this. And so this is how we'll tackle the situation. The day of surgery, we will extract the tooth, clean out the socket, use our granulation burrs to remove any granulation tissue there. Using our surgical guide, we'll position the guide to drill appropriately at the ideal angulation and depth. We'll place our implant so that it's timed with that blue line, and then place our abutment. So we've anesthetized the patient. Utilizing the physics forceps, we atraumatically extract the tooth, as seen in the slide. We identify that the socket we need to clean out further. Once we've further cleaned the socket, we'll place our surgical guide. We'll take a radiograph in addition to confirm that it's fully seated. And then in this case, we went fully guided. Adden also has a guided surgical drill kit and insertion kit. The beauty is this is one of the only kits that I've seen that actually has a 16 millimeter drill in the guided surgical kit. Most other systems you have to buy that separate, but in the Adden kit, you go all the way from 6 millimeters in length to 16 millimeters in length using guided surgery. Other things that are proprietary to the system is the keyless procedure. So the beauty is no longer do you have to use multiple keys and sleeves. This is totally keyless. Also, the design of the drill has slots for irrigation so that the irrigation when drilling goes all the way through the guide to the area that you're drilling. No longer do we get osteonecrosis because of heat generation using the active flow of the Adden guided system. Also, the way the drills are created, they are self-centering. So it enables the dentist to perform these procedures much faster and easier. Obviously, they have surgical stops, as we've seen already, and the simplicity of having a drill kit system and then having an insertion kit as well. And they have this for their whole line of implants, whether they're internal hex. They also have the close fit system, which is conical if you prefer the conical. Now here we see the 4.2 by 16 that we're taking. We have to insert and drill just a little further till the hub of that drill. Once we've completed the drilling, you can see we're going to place a 4.2 diameter by 16 millimeter length add-in OsseoFix Touareg implant. Again, you can notice the OsseoFix surface because of the calcium phosphate. You see those crystals. This increases its wettability and enhances the osseointegration. Again, something that today's society needs because people don't want to walk around with an Essex retainer and a fake tooth or a flipper. They want to walk out with a fixed temporary. So we're going to take this fully guided meaning the flat portion of the internal hex is facing that line, so that once we place our custom abutment into this area, it is actually ideally positioned so that we can place a provisional restoration. You notice it's got a high ISQ number, so we're going to place our custom abutment. This is one abutment one time. So in 4 months, when we go to place the final restoration, all I need to do is take a final impression, very similar to a crown and bridge impression that you would do for a tooth. Notice the gold hue prevents any gray shadowing, especially if a patient were to have a thin biotype. Again, we're always going to take radiographs to confirm that everything is seated. So once the implant was placed and we torqued the abutment, we're going to confirm that there's no space between the abutment and the implant. At this point, we'll put our provisional restoration on. And so here we can see in under a half hour, we were actually able to extract, clean the socket, place graft, as well as an implant, and the final custom gold hued abutment followed by a provisional restoration. Not only is this professionally rewarding for your practice, but it's also financially rewarding for that time frame that you were able to provide this. We were able to do this obviously because we went guided, and we did this fully guided thanks to the add-in guided system. So what does guided dental implant surgery provide us? Well, it provides precise and accurate implant placement. Look at the example in the top of the slide. You can see what we've planned is exactly what we executed using guided implant surgery. The add-in system is very accurate and is fully guided, so there's no guessing at all. Most importantly, using the 3D image of Cbct, there's no guessing anymore. So it reduces the risks as general dentists or even specialists when placing implants. It helps us reduce our surgical time to 1/3 of that we would normally do freehand. And in fact, when I go over these cases with patients with their Cbct, they're impressed that we're using a guided system to be able to place these predictably and efficiently. Guided dental surgery, immediately you can do provisional restorations that are fixed. We can identify ahead of surgery if some of the areas are compromised. In other words, depending on the Hausfeld units, we can tell if we need to under drill or go to the final drill size with the various Cbct views and cross-sectional areas. In addition, if we want to place several implants, it's very straightforward and efficient. In fact, there's a study, guidance means accuracy. They did a randomized clinical trial on freehand versus guided, and they took experienced doctors who did freehand surgery and they compared them and they compared the angular deviation from ideal placement to dentists that didn't normally place implants, but they did it with guided surgery. And the conclusion was that the guided approach significantly improved the accuracy of the dental implant surgery compared to freehand. So there's no guessing, and even for experienced dentists, using guided surgery still yielded better results and better accuracy. So that's something that's important and something that I've incorporated into my practice. The various types of guided surgeries or templates or guides that we can use. First and foremost, you can start with a pilot guide. In these cases, you're just using a 1.95 drill or a 2 mm drill to just do the drilling, and then you follow passively with progressive drills and you place the implant freehand. So that's one way to start without getting a guided system. You can go partially guided, where you're only able to drill, but you can't place the implants through the guide. And then obviously we have fully guided, where we can do everything from leveling bone that's guided to placement of the implants and the abutments. So let's take a look at this example. This is going to show just a pilot guide. Patient presented to our practice. The anterior incisors were all loose. Upon radiographic examination, we can see that in fact there is severe bone loss and that it would be ideal to place 2 implants with a 4-unit bridge. So we atraumatically extracted these teeth with the physics forceps. We placed our pilot guide. We take a radiograph to confirm that our placement of the guide is seated. And in this particular case, we just went with the pilot drill of the 2.0 in the 3DX kit. Once we drilled, we identified the areas with the paralleling pins to confirm that we're right on. And notice, look how tight this area is. This is the last area that I would want to do free-handed. I definitely would want to go at least pilot guide in this area. Here we can see we placed 2 3.5 by 13 implants, place stock abutments, prep them, place grafting material, and this is what it looks like upon healing. This is how the patient is healing just several weeks out from the surgical date, and the patient had gone for 2 other consults, and those providers said that she would have to walk around with a flipper first, allow it to heal, and then place implants. So we need to adapt to our marketplace and see what the demand is from our patients. And our demand from our patients is to walk out with fixed teeth, whether it's 1 tooth, 4 teeth, or a fixed full arch. Here's another example of an anterior tooth. You can see from the patient's dentition that he's a clencher. We treatment plan the extraction of tooth number 8, and then we're going to be placing veneers or restorations on the anterior 4 teeth so that he'll have a nice smile. Our goal first is to go ahead and extract the tooth and place the implant, allow it to heal, and then the patient can decide if he wants to do 2 teeth or 4 teeth. Upon radiographic and clinical examination, we identified that the mesial distal line angle did in fact have a fracture because he has a 10 mm pocket. Upon radiographic examination, we want to engage as much bone as possible without penetrating the floor of the nose. So if we were going to be placing an immediate implant on this patient, I want to go as long as possible to tap into the virgin bone apical to the root. So my goal was to place a 16 mm length implant, especially if we're going to be placing a final custom abutment followed by a fixed provisional restoration. So preoperatively, I have a surgical guide, a custom abutment, and either a template or a prefabricated provisional restoration. Again, Pittman Dental Lab provided the materials for this case as well. We anesthetize the patient. We atraumatically extract the teeth utilizing the wedge and then the physics forceps. Here we can see the separation. We've extracted the tooth, so we'll take a radiograph to confirm that the socket has no remnants of tooth structure. We'll follow with the degranulation burrs as well as curette. This is the curette from the grafting kit provided by Golden Dent. We have several of these in our office so that when we do an extraction or implant, we have all the materials ready so the assistants don't have to go in and out of the sterilization area to get further instruments. Everything is provided in one grafting kit. We'll place the surgical guide, take a radiograph to confirm that it's seated. Again, we will do this fully guided as far as the drilling, the implant placement, and then you'll notice that the abutment will be timed appropriately according to that blue line. Using the add-in system, we incrementally go to the progressively larger drills. In this particular case, we went with a 3.75 by 16 millimeter Touareg OS implant. And utilizing the insertion tools, you can see that we have this totally guided and index so that we can follow through with the custom abutment that was prefabricated. Again, this was done by Pittman Dental Lab. They do a really nice job. Shane over there does a wonderful job. He leads the implant department. And so he knows I like these gold anodized custom abutments. We like one abutment, one time. The more you screw things in and out as the implants heal, you can further create issues with the healing of that implant. So if we can place it at one time and allow that to heal, it's better for the implant and for the surrounding bone. And so here we have the immediate provisional restoration. Notice with our radiograph, we see everything was fully seated, and we were able to place 3.75 by 16 millimeter implant. So we got great torque, we got a great reading on the ISQ, and the patient was happy that he was able to walk out with a fixed provisional restoration. Let's look at our final case, which illustrates a full mouth reconstruction. Here you can see the periodontally involved teeth. Our goal is to collect the data from health questionnaire to FMX and clinical findings. We also like to take photos to document these larger cases, as well as models, whether they're analog or digital. We'll also obviously acquire a CBCT using our 8100. These are the usual 4 images that I like to capture. We'll also capture a full face shot. Here we can see we're setting our Carestream 8100 to capture not only the 2D, as you can see here, but also our 3D. Now, just looking at the 2D, what are we looking for? We want to look at the ridge of the bone. We also want to identify where the maxillary sinuses are. In addition to that, we want to identify the nasal cavity. So already we can see that we have bone in the pre-maxilla to place at least 4 to 6 implants. Now, obviously, the most distal implants will be distally angled to prevent any type of sinus lifts. So here we see the close-up of the CBCT, and looking at the cross-sectional view at number 8, you can see how, in fact, these teeth were periodontally involved and had severe pocketing and periodontal disease with bone loss. So because of this, our ideal treatment plan was extract all the upper and lower teeth and plan the placement of dental implants, 4 to 6 implants. Usually my goal is to always try to place more than less implants. So we know we're going to be doing some leveling in the lower ridge. And here on the 3D view, you can actually identify how much bone loss this patient actually has. So the treatment options we had reviewed were removable dentures, snap-in dentures, or some type of fixed. And this was the same for the lower arch. The patient chose to go with fixed over fixed. So our treatment plan was something like this: 6 over 6 implants, Notice in the upper arch, our goal is to avoid sinus grafting by angling the most distal implants. The yellow designates the 3.5 millimeter diameter in the add-in Touareg implants. The red designates the 3.75, and the blue designates the 4.2. So if we look at the 3D rendering of our plan, this is what we instruct Pittman Dental Lab to plan when designing the guides for this case. We also identified by drawing on a photograph where we want the incisal edge of the anterior teeth, and in fact that we want to correct the midline. So this is sort of a simple drawing that I'll provide for the laboratory so they get an ideal of what we want to accomplish. We don't want this roller coaster bite with this hypereruption. We want a nice flat occlusal table. So what Pittman Dental Lab did in this particular case, they digitized the models, and then they came up using exocad, a virtual treatment plan of an ideal occlusion with a flat or more ideal occlusal table. And so these are some of the things that laboratories like Pittman are able to provide for you. There's a variety of other companies that can provide this, whether it's 3DDX, 360 imaging, a variety of different laboratories. Our goal is, when doing guided surgery, to come up with something that is prosthetically driven. So they come up with the prosthetics first, and then they'll go with the placement of the implants so that we're not coming out the facial of the provisional restoration, but we're in the ideal locations to have a nice prosthetically driven implant treatment, but also biomechanically stable treatment plan. Here, if we take a look at the layout of the different guides, on the left column, you'll find all the maxillary devices. On the right column or middle column, you'll identify the lower arch materials. And then as a backup, we'll always have immediate dentures, whether we ran out of time or the quality of the bone just wasn't sufficient. I would say 9.8 out of 10 times we don't fall into that. So I'm not having dentures made, but usually it's the case when you don't have one made, you get an implant or something where you can't go immediate load. But that's very rare utilizing the add-in system. So we see the digital model at the top. The second column going down, we see the jig to position the third device, which is the bone level or foundation guide. Then we have the surgical guide for the implants. And then lastly, we have the PMMA provisionals with the holes already processed in the provisional. The beauty is this saves us a lot of time as compared to the previous ways we used to do it by retrofitting an immediate denture. Again, we said the red designates the 3.75 diameter, the 3.5 is the yellow, and then the 4.2 is the blue. So going into surgery, my assistants already have these identified, because when you're doing a major surgery like this, where you're extracting, leveling, grafting, implant placement, abutment placement, and provisional, we don't want to be guessing of what implant goes where. So we almost have a map of everything that we're going to be doing. Again, the Touareg implant, as we talked about already this evening, has high primary stability. It's got a condensing property as well as a self-tapping ability. So this is my go-to when doing any type of immediate load, especially with the OsseoFix coating. So our goal is to reflect the flap utilizing the reflector from Golden Dent, positioning our jig, removing the jig and leveling the bone to that level. And then once we've leveled it, we'll put the surgical guide. Notice the blue lines are for the timing of the internal hex. Again, the beauty of the add-in guided system is you have the built-in stoppers. The drills go from 6 to 16, which I have not seen yet out in our profession. It's a keyless system, which is nice, no more keys. It's self-centering, and most importantly, irrigation goes through the guide because of the angled channels or the active flow irrigation technology, which is proprietary to their system. Once all the implants were positioned and the abutments, these are the temporary cylinders. So we'll position the PMMA temporary with the holes already prefabricated. This saves a big amount of time. It makes the procedure very effective and efficient. While we're having our lab technician trim that down, we're going to go ahead and start with the lower arch. So we position our bone foundation guide with the jig. We'll level the bone and place our surgical guide, place our abutments in addition to the temporary cylinders, ensure that our temporary fits, and then go ahead and do the retrofit of that. So in this case, we were able to go to start to finish, extracting all these teeth, leveling bone, placing the implants and provisionals in about 3 hours. So about an hour and a half for each arch. There's no way that I'd be able to do that start to finish without utilizing guided surgery, and especially a system as effective as the guided implant system from Addon. 3 to 4 months later, we'll go ahead and do a pickup. My material of choice for impressions is the Kettenbach dental material, the Panasil, but this is their bite registration, which is the Futard D. When this sets like acrylic. So here we don't want any mobility or distortion in the impression. We'll ligate these with floss and then utilize the Futard D, which acts like acrylic. And then we'll do an open tray impression. And this way we don't have to worry about our final restorations fitting or misfitting. So we have a good impression to be able to go to a wax try-in, confirm that we're happy with the bite, make any necessary adjustments, and then take a new bite with the Futard bite. And then from there, the laboratory will go to the final restorations. If we wanted to make another PMMA, our laboratory could fabricate another PMMA, but we found that everything was good and the patient was happy with the selection of teeth. So we had the laboratory fabricate a zirconia monolithic with a titanium frame. I'm finding I like these much better than the pure zirconia with the housings, because every now and then you would get a delamination of the housing. So my go-to on these restorations is titanium frame with zirconia. Here you can see we've positioned and torqued it down. You can see the healthy gum tissue. These are ovate in nature in the underlying surface so that the patient can go with superfloss or a water pick. We do not want modified ridge laps or ridge laps. Those will retain food and debris and later cause peri-implantitis. Looking at the final radiograph, we can in fact see the ideal placement using guided surgery. So this evening we covered placing implants with a system that allows you to get good fixation until osseointegration, and that was using the Addon system. We also identified utilizing not only the physics forceps, but a lot of the other surgical components from Golden Dent to be able to atraumatically extract teeth and preserve as much bone as possible, or further clean out the socket before we place implants, to be able to provide, whether it's single implants and restorations to overdentures to eventually fixed restorations. I thank you for your attention this evening, and we'll open up for any questions.
Well, not quite yet.
Oh, okay.
Yeah, as I mentioned at the beginning, we are very fortunate to have Golden Dent sponsor these webinars. They brought in Dr. Nazarian. They handle all the aspects of running the webinars. So I wanted to turn it over for Kurt Lawler from Golden Dent. He will talk about a special offer that they're going to make. And also, one of the big things with these systems, of course, is making sure that you know how to use them. And so he's going to talk about the educational opportunities as well. So Kurt, take it away.
Thanks, Lauren. I appreciate it. My name is Kurt Lawler. I'm from Golden Dent. We're a dental manufacturer as well as an educational company based here in Detroit, Michigan. I know a lot of our attendees join our webinars on a regular basis, but if you're new to Golden Dent, welcome and thank you for joining this evening. So I'm just going to get through a few slides here. I'm going to speak kind of quickly so I can save enough time for the Q&A session. But as everybody knows, 2021 and 2020 have been some challenging years, and I've been hearing more and more on the phone that some companies do not have regenerative materials in stock, or having supply issues, or maybe delays and price increases. And I just wanted to mention, we have not had those issues yet. So we do have supply of all of our allograft, whether it's particulate or putty, membrane, sutures. We have a good stock of everything here at Golden Dent. And it's actually the same pricing we've had here in the last couple of years. We haven't changed anything. So for joining the webinar this evening, we usually provide a promotional offer, and we'll do that again this evening. This is actually one of the best ones we've done in a while. So it's 15%, and the code is WEB15, so it's just WEB15. And if you saw anything this evening that was interesting to you, I'll go through and recap a couple of the products here in just a moment. But you can learn more about them at golden-dent.com. And then our Amplified Dental is the educational component of our product-based business. We do these deals that are good, and we do the deals just for 24 hours. So tomorrow, November 3rd at midnight, you can use that WEB15 code on any of the products that you saw this evening that are Golden Dent-based products, and save 15%. So Physics Forceps, that's what started everything kind of for us here at Golden Dent in 2007. I'm not going to go over this in too much detail because Dr. Nazarian already went over the technique and how they work and kind of how they're packaged here. But this standard series set is our most popular set of instruments. This is the ones that, like I said, started what we do here at Golden Dent about almost 15 years ago now. And there's 4 instruments. So there's 1 lower and 3 upper instruments. And these are going to be the easiest to use, and make sure you like the concept and the technique on using the system to extract teeth. We do have 1 other set of instruments too that are more for like posterior teeth, which is our Molar series, which I recommend to start with these first. These are easier to use, and we'll generally do second molar to second molar in the upper and lower arch anyways. You can use, do you elevate in advance? I mean, you don't have to. The Physics Forceps it's really a lingual elevator versus a forcep, but Dr. Nazarian's choice is there at the top. It's called the wedge. So we do have that instrument, but you can obviously use a different type of an elevator or luxator if that's your preference. These are standard extraction forceps. We added some new features. Made them like scratch and corrosion resistant, made them a little bit more lighter weight, changed the beak designs. It's a nice set of your conventional instrumentation, like a 150 or a 151. So we do have those available under our Golden Force line. This is a complete graft kit. So when we do our grafting programs, we always found that people were kind of looking all around for different instruments, maybe do that in your own private practices. This is just a nice set to have set aside for your grafting procedures. It's relatively inexpensive. Everything fits in the cassette, and then you have all the instruments you need when you do your grafting cases without having to kind of look around for each individual instrument. I think the pricing on this is it's like $450 or something like that with the cassette. So it's not too pricey, and they're good quality instruments and keeps everything organized for you for your grafting procedures. This was shown quite a bit. This is our degranulation and bone shaping burr kit. So I won't go over that in too much more detail since it was already shown this evening. Our graft material. So if you are using another bone graft or a particulate, or whether it's a putty from a different source, like I said, we always have it in stock, and we think our pricing's fair. So if you are using another brand, this might be a good opportunity to try our Goldos brand. It's a good high quality bone graft. The plugs, I know this wasn't discussed too much in this webinar. It wasn't the the perfect topic to talk about the plugs, But this is a really, really popular product for us. I highly recommend looking at this if you're not using this product. It looks like a collagen plug, and it has a bovine collagen carrier, but it does have a calcium apatite synthetic crystals inside the collagen, and so it actually is a bone graft. It's a great way to get involved in bone grafting. It's very affordable, and you don't need to use a membrane. Something definitely to look at. There's tons of videos on the website that show how this is used. This is a curette that we have. We were asked to make a serrated curette. This is perfect actually for use with the osteogen plug, just to go ahead and clean out any granulation tissue from the socket prior to the grafting procedure. So I just want to mention this is something that we have that's maybe new since you've joined a webinar recently with us here at Golden Dent. Membranes, the one we really like is the EpiGuide, the one there on the left. They're all long-lasting resorbable membranes. They're all going to really perform the same type of function, but the EpiGuide is probably the best one from a handling perspective if you wanted to take a look at that membrane. Sutures, we have a great PGA suture, and then a black silk suture that's really inexpensive. That goes with our BioViva brand. If you want to take a look at those. And then I want to just mention this. So we don't currently sell dental implants, but since I know we're going to be asked, since we did show the Adene dental implant system quite a bit this evening, this is the contact information if you did want to learn more about the Adene implant brand. It looks like they have some sort of a promotional code, which is Adene, ADIN 1121. And I'm not sure what that gets you exactly, but if you do want to contact them or have any interest in learning about their implant system, you can give them a call, or they're obviously always at our educational programs, which I'll talk about here in a second. So we do a lot of educational courses in addition to the products that we distribute and manufacture through Amplify Dental Training. These are just some of the past photos from the programs. We do a lot of classroom-based courses, and we do a lot of live patient programs. So the next one, it looks like coming up is February 4th and 5th. That seems like a ways out, but it'll be here before you know it. This is one that is going to be much more comprehensive, obviously, than what we were able to cover this evening, in just a 45 or 50-minute webinar. This will go over in great detail how to do cases like the last one that was shown this evening with the guided full arch implant reconstruction. And it's not a live patient program. It's all done on model work in our facility here at Amplify Dental. But it's a really great experience to understand full arch guided dental implants. So you can learn more about that program at the website under Amplify Dental. Our next extraction course, which is live patient based, is coming up at December 11th. This is a live patient course. So if you come from Canada or any of the 50 states, you can work on the patients because we do the programs at a teaching facility, and there's no licensing restrictions in that regard. So you will be doing all the extractions and grafting at this course yourself. So we usually see, anywhere 65, even up to 100 patients, just depending on the patient flow and how many doctors we have attend the program. So the next one's December 11th for this year to round out the last program for 2021. So totally off topic, but I want to mention it quickly, is March 4th. So this is also a program with Dr. Nazarian. So in addition to the implants, he actually also teaches our endo course. And so this is the endo for the GP program. It's also a hands-on model training course here at our office. And the next one is March 4th. This is, again, totally off subject, but I'll mention it real quick before I turn it back to the Q&A, is we have a complete full endo line. We obviously go over this in great detail in our endo training courses, but we have really great products that we have, like a Pro Taper and a Wave 1 comparable type file. We have this new AI motor, which is the Woodpecker brand. They're making really great products, as well as fiber posts, pins, and really a full endo type line. If you're interested in anything like that, you can use a promotional offer on these products also. So that's it. I apologize if I talked too long. 15%, web 15, and I will turn it back to Lauren to start going over the questions with Dr. Nazarian. I appreciate everybody. Thank you.
Thank you, Kurt. We appreciate it as well. Ari, you ready?
Absolutely.
Okay, so I'm going to read some of these questions. I'm just going to read this verbatim for you. So someone was mentioning that they were struggling a bit with the Aiden implants. For example, if I'm placing a 5mm implant, my last drill is 4.2, the implant will stop going forward. Then I remove the implant and I would use the drill 4.6, then the implant will be loose in the osteotomy. What is your advice to overcome this problem?
So the first thing I would say is, what type of bone are you placing the implant in? If you're placing it in a dense bone, then you obviously want to go with the larger size. If you're going into like a type 3 or type 4 type of bone, then you want to use the smaller drill. So I guess the question would be, what type of bone are you putting it into? So if you went to, let's say, bone that's not that dense, then you should be able to go to the final. Or what I would do is don't go to full length with the larger size drill, but just go halfway down the size. I would say that would be more doctor's experience and use as compared to the system. They are aggressively threaded, so you have to know the drilling sequence to follow when placing them.
Okay. On the delivery of the immediates, what occlusion do you make? Group function, canine guidance, something else?
So are we talking about an individual tooth, or are we talking about a full arch?
Well,
Because it's
he doesn't
different.
specify, but
Yeah,
give me both.
I'll give you all of them. So if you're doing a fixed provisional restoration on a single tooth, and again, I'm not putting a provisional on something like a posterior tooth. If it's a premolar, and the patient's very conscious about that, and I have good primary stability, and I've gone into apical bone from the socket, then we'll put a fixed provisional restoration. When doing a fixed provisional restoration on one implant, that implant is not in function. In other words, they may have some function. If food gets in between there, we instruct them not to chew with it. But if we were to articulate it, there would be no occlusion on that implant, because you have other teeth that you can rely on. Obviously, if you're doing a full fixed arch, then you're going to have the bridge or the hybrid that's in occlusion. In those, we use a protected occlusion, where we have the anterior teeth contacting more so than the posterior teeth. But if the patient does go into lateral or protrusive movements, if they go in lateral movements, they will get canine rise and guidance. And if they protrude, then the anterior teeth will ensure that the posteriors disclude. So we're doing what we call a mutually protected occlusion, not balance, not group.
Okay. When you do a pilot guide, does the lab do a mock-up of the final teeth desired so the implants are placed directly under the coronal aspect?
So depending on if it's going to be a screw retained restoration or a cement retained restoration, that will indicate if the laboratory will put the sleeves slightly more lingual or out the incisal. So let me explain. If it's a cement retained restoration, then we want that access hole to be coming out the incisal edge. If we're doing a screw retain restoration, then we want the access hole to be in the cingulum or slightly lingual to where the incisal edge is. So it all depends. In the bridge example, as everybody saw, with the 4 centrals that we removed and we placed a bridge, notice that was not screw retained, so the incisal edge dictated the entrance of those abutments that were cement retained.
Okay. Questions for me here. So as a reminder, this webinar was recorded. Typically that recording will go out in a few days. I think they actually just make it into a YouTube video and send out the link, but either way, you'll be given that information. CE forms usually take a couple of weeks, but there's nothing that you need to do. As long as you were on for the webinar, sit tight, just check your inbox. It should come out within a few weeks. There's no quiz or registration or anything like that. When you're done, you just sign out and you're done for the evening. Okay, how long have you been using the Aiden implant? Any comments on waterless 75-50 osteotomes in terms of pressure necrosis? Thank you.
I did understand the second half of that question, sorry. I
Well,
don't
how
know what
about
those numbers mean. So the
Okay,
Aden
well,
I've been using
the
for
first part.
several years, and different generic systems like it. I've always been an advocate for aggressively threaded implants that are on the market, whether it's a Noble Active or any other implant that's aggressively threaded. However, we want something that's cost effective in addition to be aggressive, and something that can support all types of prosthetics and digital components. There have been other implant companies in the past that may have an aggressive system, but they're not able to support you digitally when it comes to prosthetics or with multi-unit abutments. So the Aden I found works the best, and I've had no problems, or a least amount of problems, I should say, with those. Usually if there's a problem, it's the quality of the bone, and then I will under drill in those situations. But from a company standpoint, not only surgically, but prosthetically, the support is there, and it's a company that stays on top of all the various things in implantology.
Okay. One of the slides you showed some blue lines on the device to align the abutments. Can you just explain what that was?
Yeah, so when we're drilling, we'll drill until the hub goes to the sleeve of the surgical guide. The slots or the blue markings are not for the drills. Those are as we're placing the implant. In this system, it's an internal hex. So there's 6 flat parts to that implant system. So we want that flat going towards the line, because as we saw in the maxillary anterior cases, those implants are angled. And so we need to index, right, where that flat is, so that when we put the abutment that's already been pre-milled, it's not going a little bit too far to the distal or the mesial, but it's actually timed and positioned so that we can put a prefabricated temporary or make a temporary, and we don't have to trim the abutments. Notice in both CAD/CAM examples, there was no gold hue missing from the abutments because I didn't have to adjust them. So yes, you're paying for a final abutment at the time of seating, but you're never going to have to take that off to take a new impression. All you have to do essentially is take a crown and bridge impression. So it really makes dentistry very easy to implement using guided surgery.
Got it. Okay, next question. When there is significant tabling of the bone, how do you handle the soft tissue to end up with attached keratinized gingiva around the implants?
Can you repeat that again? I'm sorry.
Yeah, when there is significant tabling of bone, how do you handle the soft tissue to end up with attached keratinized gingiva around the implants?
When there's severe what? I didn't get that word.
Significant tabling.
Oh, tabling, like leveling. Okay.
Yeah.
I didn't hear it properly. Okay,
Sorry,
so
my Canadian accent.
yeah, that's okay. So when leveling bone, we're obviously going to reflect the flap. So when we reflect the flap and you remove or you reflect that portion that's connective tissue, when you readapt it, you're readapting it apically. You're not cutting all that keratinized tissue off. So the misconception in that question is that we're cutting off all that excess gum. We're not. We're apically positioning the flap. We may just trim off the interdental papilla, but we're apically positioning and suturing the flap so that there's keratinized tissue around the implant. The concern in the question is, yes, if you remove all keratinized tissue and cut it, then if you have movable mucosa, an implant will either fail or cause a lot of discomfort for the patient. But we don't cut all the keratinized tissue. We actually apically position the flap.
Got it. Okay. Are there any courses either through what Golden Dent does or Amplify that that look at overdenture cases as part of the education?
So this weekend, we're actually doing quite a bit with overdentures. The original or the first portion of the course is actually all didactic and hands-on on models. And then the live portion, the second day, is actually the doctors remove teeth, level bone or table as was indicated, the bone, and then graft. We don't put implants at the dental school where we're doing the courses, but we do instruct on that with the hands-on portion the first day.
Got it. What's the max torque do you put on the mandibular molar area?
So I never want to exceed 70 or 80 Newton centimeters of torque. If we start going into 90s and 100, then you can potentially create osteonecrosis with an aggressively threaded implant system. If you're already like halfway down and you find that this thing is not seating to the full length of the osteotomy, then don't try to force it. You want to back it out and go with a larger diameter drill or go with a step size type of drill so that you don't over drill as was brought up earlier. So that all really comes with experience of a system. I don't recommend starting with an immediate implant placement and a fixed temporary on your first implant case, obviously. I would do more of a delayed prosthetic restoring of that type of thing. But it's something that we teach at the Amplify Dental courses, whether it's the beginner courses, the middle range courses, or the fully advanced full arch courses that we teach.
Okay. And what was the name of the course that you said that you were doing this weekend?
This is the AMP 3, which you can find on the Amplify Dental website. And this is the setting the foundation for immediate dentures and overdentures.
Okay. Are there any statistics or any studies that you know of that compare failure rates of immediate load single tooth implants and full mouth compared to like a delayed load?
I can't really quote one, but I've read several, and essentially there's a lot of variables that can cause different reactions of an implant failing or being successful. The immediate load, as long as you are removing infection and you're not putting the implants in with too high a torque, you're going to find that they're going to be successful. Usually an implant's number one failure is overload. Overload meaning that the occlusion in the prosthetics is too heavy. Remember, a tooth has a periodontal ligament, so it compresses somewhat. An implant does not. So if somebody's a grinder and they're in heavy occlusion on an implant and all the other teeth compress, guess what's taking all the force? The implant. And doesn't matter what system it is, it's either going to get bone loss to where you can eventually lose the implant. The second most common reason, I guess, for an implant failing is contamination. Whether, let's say, for example, you're placing an implant in the lower ridge and you haven't isolated the area, and when the patient swallows, a pool of saliva contaminates the implant before it's completely submerged into the bone, that has a high incidence of failure because it got contaminated. So there's a lot of variables that can cause an implant to fail. If a patient has got very low vitamin D or an antidepressants, that can also cause failures. So I don't know if any study that would say, well, one thing causes more failures than others, but I can say immediate placement is something that we do probably 65, if not 75% of the time. And if I ever do get failures, It's not because I immediately loaded. There's usually some underlying variable that caused the failure of that implant, no matter what system.
Right. Okay, last question before we wrap it up. When you expose the gingiva to leveling the bone, do you expose the mental foramina?
Depends on how much I have to level. If I have to, then yes. If I have to reflect a big flap and I have to do a lot of leveling, if we do it like the example that you saw on the first one that was non-guided, obviously it was more of a mini flap. So in some cases, yes. In some cases, no. Experience teaches you where that is and to respect it, but not to be terrified of it.
Right.
And that's
Okay.
another thing to teach.
Yep. Well, I promised we'd be finished up at the bottom of the hour, and we're at the bottom of the hour. So anything you'd like to say before we wrap it up for the evening?
No, again, I appreciate you, Dr. Levine, for giving us this platform to be able to share this information with our colleagues. I appreciate everybody's attention and questions. And if you have any further questions, feel free to reach out to us at Amplify Dental and take a look at some of the courses we have. The beauty is that we do have hands-on courses with live patients without having to leave the country. So if this works for you, definitely give Kurt and his team a call. Otherwise, thank you on behalf of me.
Well, we thank you because we know your time is valuable. I know you do a lot of lecturing, a lot of stuff other than treating patients, and we appreciate you taking time out of your busy schedule for educating everyone this evening. As I mentioned, thanks to Golden Dent, I would certainly highly encourage people to take advantage of these specials. You know, they're one of the things I always say about Golden Dent is they say what they mean and they mean what they say. So when they say that 15% is good until midnight tomorrow, it means if you call on Thursday, they're not going to be offering it. So I would highly recommend you take advantage of that. The code there is the Web15. Take advantage of the educational opportunities that are available for you as well. And we thank Golden Dent for sponsoring these webinars. We do these on a regular basis, usually every 6 weeks or so. So keep an eye on your inbox. As I mentioned earlier, the recording link will go out sometime in the next few days. The CE will take up to a couple of weeks. And then we certainly will send out invitations for our next scheduled webinars. So please stay safe and healthy out there. And we look forward to seeing all of you on future webinars. Good night, everyone.